we've got two cases here. That shows the important relationship between the esophageal pathology and the pneumomediastinum and pneumothorax. So, if you have a history of esophageal cancer and esophageal stent placement, as you see here, you need to look for pneumomediastinum and tension pneumothorax. In this case, if you see on the chest X-ray evidence of pneumomediastinum, you need to think of esophageal perforation as the most likely cause. In this case, this patient has esophageal stent placement, as you can see here. This patient has also esophageal stent placement. So the first case, history of esophageal cancer with previous esophageal stent. And now there's chest pain. Chest radiograph of an adult male patient showing an appropriately positioned esophageal stent. The first thing you need to look for is pneumomediastinum. No evidence of pneumomediastinum. However, the second thing you need to look for is pneumothorax. In this case, however, there is a small left-sided pneumothorax. This is the pneumothorax. This is the edge of the lung. This is the edge of the lung. And this is the pneumothorax. However, there is a small left-sided pneumothorax with some features of tension. The features of tension here seen as mild depression of the left hemidiaphragm, and you can see here widening of the intercostal spaces. Look here the distance. Widening of the intercostal spaces and mild depression of the left hemidiaphragm. The appearance is consistent with a tension pneumothorax. Tension pneumothorax is an emergency. I would urgently convey the findings to the referring team and recommend a chest. I would urgently convey the findings to the referring team and recommend referral to a respiratory unit and referral to a respiratory unit for a possible chest drain for the pneumothorax if the patient has any degree of clinical compromise. So in this case, esophageal pathology Evidence of esophageal stent means you need to look for evidence of pneumothorax or evidence of pneumomediastinum or pneumothorax. If you see tension pneumothorax is an emergency. You need to urgently refer the patient to a respiratory specialist for a possible chest drain insertion for this pneumothorax. Next case, chest pain in elderly men, acute admission to the hospital. Anteroposterior chest X-ray in a skeletally mature patient demonstrates evidence of esophageal stent is seen here in this patient with air within the mediastinum with a continuous diaphragm sign. Air within the mediastinum with a continuous diaphragm sign. This continuous diaphragm sign is pathognomonic for pneumomediastinum. Once you see pneumomediastinum, you need to consider esophageal rupture as the most likely potential cause. Here there is evidence of esophageal pathology seen as esophageal stent placement. You need to check for evidence of pneumothorax. No evidence of pneumothorax here. Pneumomediastinum usually associated with soft tissue emphysema. Soft tissue emphysema, evidence of soft tissue emphysema is seen here as air within the subcutaneous tissue, visualized as vertical lucencies in the soft tissue. The lungs are hyperinflated with scarring in the apices, with no consolidations, no acute bony injury. Imaging features are in keeping with pneumomediastinum with soft tissue emphysema, Potential causes for this are ruptured esophagus due to possible Burhave syndrome. So, once you see pneumomediastinum and soft tissue emphysema, the most likely cause is ruptured esophagus due to Burhave syndrome. Then, traumatic rupture of trachea or bronchus, traumatic rupture of the trachea or bronchi or alveoli. These are the potential causes for pneumomediastinum. Pneumomediastinum is a medical emergency, the same as tension pneumothorax is also a medical emergency. I would urgently convey the findings to the referring team and discuss the clinical history with the referring physician to detect the potential cause. You will find from discussing the clinical history of the patient with the referring physician that an esophageal pathology denoted from the esophageal stent placement. I would also recommend a CT scan if the patient is unstable, or a water-soluble contrast swallow study if the patient is stable. So, the management of the pneumomediastinum is by detecting its potential cause, either by discussing the clinical history with the referring team or by the patient undergoing a water-soluble contrast swallow study to exclude the esophageal rupture if the patient is stable, or to detect the esophageal or tracheal or alveolar cause by doing a CT scan if the patient is unstable.